Welcome to VA Claims Confidential. I'm Mr. X. I'm the guy behind the guy, giving you all the information you want to know. All the information you need to know about the VA claims process. VA's objective is how to maximize your VA knee evaluation. First, you got to understand the process. What type of claim are you going to be filing? Is it going to be on a direct basis? Meaning, is there something in your service treatment records that show you were seen in service for treatment of a knee condition or a knee injury? Are you claiming it's secondary? Is the issue related to a service-connected back issue, service-connected hip issue, service-connected foot issue, or possibly is it related to your other service-connected knee? Are you filing for a claim for increase? Are you already service-connected for a knee condition and wanting an increase? Or is this like an aggravation claim where the knee condition existed prior to service and now and it was aggravated by service and you're seeking service connection for that? To really maximize your possible knee evaluation, first you got to gather the evidence, okay? Go through your service treatment records. Is there anything in service that shows that you were seen in service for a knee condition? If so, show on your claim, hey, I was seen in service for a right knee condition on January 1st, 2002. Offer up any lay statements, any statements that you want to provide that isn't already in your service record. You can write a statement about how you injured the knee. Additional medical records, if you were seen outside of the VA by your private healthcare provider, submit those records with your claim. Is there any buddy statements that you want to submit? Do you have a battle buddy who knows of a knee injury that you suffered while in service but are not in your service records? Then have them write a statement and submit it with your claim. Last, you can always submit a nexus letter of private opinion. That's not my first recommendation just because it's not guaranteed and you have to pay money out of pocket for it. I'm not against them. I'm not for them, but it is an option and a method that you can use to increase your knee evaluation. When it comes to the exam, okay, this part is crucial to determine the severity of your knee condition. Okay, it's all going to come down to the exam. Couple tips here. First, be honest. That's my first recommendation for everything. Be honest. Be open about all the symptoms that you experience. Be detailed in them. Talk about your pain levels on a scale of 1 to 10. What is the pain level range as? What is the range of? On a scale of 1 to 10, are you at a 5 on a daily basis? What is it in the morning? What is it in the midday or after a long day? Talk about your pain levels. Range of motion is one of the most important things. And it's often not talked about too much. We're going to go through on this video, okay? Last thing is other functional impairments. Anything that might impair range of motion of your knee. Do you have braces? Do you have other impairments like this or catching on in the joint? Make sure that you talk about all your symptoms that you had in the exam. Let the examiner fill out the form, but go through everything. Don't be shy. By the way, we're going to go through the VA rating schedule 38 CFR Part 4. Okay, Part 4 contains all the diagnostic codes for any disability that you put in for you. It contains the evaluation criteria to accurately evaluate and rate your symptoms, okay? So, in going through this rating schedule, first and foremost, your knee, your diagnosis determines the diagnostic code used in the VA rating schedule. Okay, you can have technically up to 4 different evaluations for your knee. Generally, you won't have 4. You might have 1 or 2, sometimes a third, if that. First one, diagnostic code 5260. This has to do with the limitation of flexion of your knee. 5261 has to do with a limitation of extension. We're talking about reduced range of motion. Okay. 5257 has to do with knee or other impairment. It talks about subluxation and instability, and also even specifies patellar instability on top of that. And the last one, 5258 and 5259. This has to do more so with your cartilage, semilunar issues. Generally, this is your meniscus or in that area, okay? So, when your knee is evaluated, you may or may not know which one you have, whether it's a 5260, 61, 5257. But if you see information that says in the code or in the diagnostic information saying a painful motion of the right knee or limitation of flexion right knee, it's 5260. So we're going to go through the rest of what each of these codes mean. The VA rating schedule 38 CFR Part 4. Okay, this is the part in the VA rating schedule which separates all the different disabilities that you can be service connected for, assigns a diagnostic code, and based on the diagnostic code, there'll be different rating criteria for each disability. Okay, so you have to understand the VA rating schedule to maximize your knee evaluation. Okay, so essentially your knee is broken down into 4 separate categories or 4 separate diagnostic codes. You can have up to 4 separate knee evaluations if you meet the criteria for all of these. Okay, first one, 5260, has to do with the limitation of flexion. We're going to go through all that and tell you what that means. 5261 talks about limitation of extension, and you can't extend your knee out all the way. 5257 has to do with subluxation, instability, patellar instability. This has to do with sprains and tears of the ligaments. And your 5258, 5259 has to do with your cartilage issues. This is mainly your meniscus, okay, your semilunar cartilage of your knee. So, and talking about 5260, what this means, you'll see the 5260 limitation of flexion. Look on the right-hand side. There is an example of the range of motion of your right knee. Essentially, you can go from 0 to 140. 0 is essentially where your knee is all the way flexed out straight. 140, if you're sitting in a chair, indicates that it's, the leg is positioned underneath the seat. In the photo there, or in the image, it shows that it's directly in your buttocks. Now, depending on what your range is, will determine on the criteria for which you're entitled to. So, for example, like the image on the left, if your flexion is limited to only 15 degrees, which means you're not moving your leg too much, it could be a 30% evaluation. If your flexion is limited to 30 degrees, that could be a 20% evaluation, and thereon down. We look at 5261, has to do with your limitation of extension. Okay, so once again, you have the image on your right there, talks about your range of motion, 0 to 140. Now, if your extension is limited to only 45 degrees, that could yield a 50% evaluation. You can see the image on the left explains everything. If the extension is limited to 30 degrees, then it could be worth a 40% evaluation. Ultimately, I know you look at the right, you look at that image on the left and see a 50% evaluation could be warranted for if your extension is limited to only 45 degrees. But please know that if your knee is limited to that kind of extension limitations, then you're not moving too well. I'm pretty much guaranteed that, okay? Now, 5257 talks about knee other impairments, recurrent subluxation or instability. So look at the 30% evaluation. It says, unrepaired or failed repair of a complete ligament tear causing persistent instability, and a medical provider prescribes both an assisted device, which is a cane, crutch, or walker, and bracing. So you have to have a diagnosis of all of that, okay, to warrant a 30% evaluation. If you look on down to what warrants a 20% and a 10% evaluation, it talks again about a sprain or incomplete ligament tear. Now, this isn't just one of those things where in your treatment records, you're self-diagnosing and saying, hey, I sprained my right knee. This is a actual sustained diagnosis that the medical doctor has provided, that, a sprain of your right ACL, your right MCL, your lateral collateral ligament. It's got to be something that is specific. And if it causes persistent instability, then depending on if a brace is prescribed, then that could warrant a 10, 20, or 30% evaluation. Lastly, 5257, this is continued on. For your patellar instability, once again, thoughts about the instability, recurring stability after surgical repair, and whether or not a brace is prescribed. Let's go to note 2 there at the bottom. Let's go through that. The surgical procedure that does not involve repair of one or more patellar femoral components that contribute to the underlying instability shall not qualify as surgical repair for the patellar instability. Okay? All these things you have to be aware of. Lastly, in 52.8, 58, and 52.59 talks about the meniscus, semilunar cartilage issues. So to get the 20% evaluation, now you got to look at commas and wording of this. So you have to have an injured meniscus has to be dislocated or torn with frequent episodes of locking, pain, and effusion into the joint. So if you have 2 out of the 3, that's not enough to warrant the 20% evaluation. You have to have the episodes of locking, pain, and effusion in the joint. Lastly, if you've had that cartilage that's been removed, and you're still having symptomatic residuals, meaning, let's say you have locking and pain, but not the effusion, that's going to warrant a 10% evaluation. Okay? So you have to know, going into the process, going into your exam, what each of these mean. That way you can be upfront with the examiner about what symptoms you're experiencing. Do you have limitation of flexion, limitation of extension? Do you have instability? Do you require a brace? Do you have a meniscus issue? These are all things you need to be aware of and speak to in your exam. That way the examiner can correctly input the symptoms that you have and are living with on a daily basis and put that into the DBQ. And then the VA rater can take that information, put it in the system, and generate the evaluation that best suits the symptoms that you're experiencing. When it comes to the exam, all the exam forms are all public information, okay? This is the file path to where to find all of the exams, all those public DBQs. It's all written out right there. And I'm going to show you another separate video here right after this. Of how quick and easy it is, you can go to it, look it up, and be aware of what each DBQ shows, not only for your knee evaluation, but if you put in a claim for a low back and neck, if you applied for GERD, they're all, the DBQs are listed right there. Okay? So let's go through that. Okay, so let's go through and I'll show you how easy it is to find the DBQs, okay? VA website here. Okay, going to go to Veterans Benefits Administration. Left-hand side here, we're going to click on the Compensation tab. Go down to Compensation and Pension Exam. May open a separate window. On the right-hand side, you'll see this tab here. Public Disability Benefits Questionnaires. And if you scroll down from there, it's going to list all the different ones for each body system: cardiovascular, dental, dermatological, endocrinological, ear, nose, and throat, and on down from there. Okay? Let's go through it one more time just in case. Show you how easy it is. DBA, boom. Compensation, right there. Compensation and Pension Exam, right-hand side, Public Disability Benefits Questionnaire, and then you're home. Bookmark that, and then next time you go in for an exam for any one of those conditions, then at least you know what to be prepared for and what the examiner is going to be looking for. That way you can better speak to the symptoms that you're experiencing. Okay, the real reason you're here. Let's go through the DBQ now. All right, let's go through the knee DBQ here. Go through all the information here. The standard stuff here at the top, talking about your name, social, date, and exam. Okay? Scrolling down from here. As you can see up here at the top, it's 14 pages. Page 2 talks about the diagnosis. Do you have a knee strain? Is it meniscal tear? Is there an ACL tear? Right side, left side, or both? And then the date of diagnosis. Scrolling down from here, you'll see the medical history. This is all subjective information that the examiner puts in. Anything that you tell them, they're going to summarize your medical history. Hey, they were seen in service for their right knee injury on January 1st, 2002. They had a recent surgery and January 2022, etc., etc., okay? It's all just going to be information in here. Going down from here, gets into the range of motion here. Now, when it comes to the range of motion, the examiner needs to use a goniometer, okay? Goniometer is essentially a protractor to determine the range of motion measurements for the body, okay? If the examiner is having you do range of motions and then they're trying to determine that it's not a goniometer, then politely ask them what the range of motion is and how they came to it. If you still don't see them use a goniometer, ask them, hey, I thought you were supposed to use a goniometer in determining the range of motion. If not, then have them so specify. But keep in mind, be nice, okay? Now, we're not trying to be nice just to hopefully, get a better evaluation, but we're being nice because, you know what, they're humans. They can make mistakes too, all right? So, goniometer, have to use it. Going down here, this is where they're going to show the range of motion, okay? Whether or not, let's say you're 140 over 0, do you have full range of motion? Is it limited? And if it's limited, they're going to show a reduced number here. Is your flexion endpoint, is it, reduced to 45 degrees or 60 degrees? We put this information in here. If there's pain or painful motion and the flexion or painful extension, they're going to so indicate here. Going down, there's a second range of motion measurements here for observed repetitive use. They're going to include the range of motion measurements here, and then also there's additional factors that essentially equal functional loss, whether that's additional pain, fatigability, weakness, lack of endurance or coordination. Then you'll do repeating use over time. Once again, based on that, they're going to determine the range of motion, put another number there, and during flare-ups. At the end of the day, if it's just that, if you are having a flare-up or the range of motions, okay? The examiner is going to indicate all of these on the exam. Keep scrolling down. Is there muscle atrophy? Has your muscle weakened because of it due to the diagnosis? If so, they're going to indicate it. Is there any ankylosis? I sure hope not, because that means your joint is essentially frozen in a favorable or unfavorable degree. Okay, you don't see this one too often, and that's good. Joint stability. Okay, if there is, this is the 52, 57 part. They're going to say, is there subluxation or persistent instability? If so, why is there? Has there been a complete tear or incomplete tear? Continued on. Okay. Was it repaired, yes or no? And then, if it was repaired or not repaired, are you prescribed a brace, crutches, walker for ambulation or walking? Next part, talking about patellar instability. Do you have it? Was it repaired, yes or no? And do you have, are you prescribed that brace or walker for ambulation? Okay. Going down here a little bit more. Talks more about tibial impairment or fibular impairment, specifically shin splints. If you have anything, they're going to indicate it so here. Shin splints is going to be a whole separate video at some point about the rating criteria for shin splints. Is there a discrepancy in your leg length due to your knee disability? If so, they're going to indicate there. Okay, going down here, do you have a meniscus issue? If so, they're going to indicate. Now, remember, with meniscus, to get that higher evaluation, you have to have the tear, you have to have joint pain, locking, and infusion into the joint. So, to equal that 20% evaluation, they got to check all three of these boxes. Okay, there's a surgical history. They're going to indicate what that is. Did you have a meniscus repair? Did you have, jet knee scoped? They're going to indicate here. Scrolling down some more. If you are prescribed assistive devices, they're going to indicate again here. Now, as you know, and as we've just shown with the instability, it shows up there that, whether or not you're prescribed an assistive device, but this is kind of another fail-safe area that, hey, if you fail to include it above, here it is again. Okay. Talk about remaining effect or function of the extremities. Is there any functional impairment or additional functional impairment that hasn't been described previously in this DBQ? Next section talks about arthritis. Is there arthritis, yes or no? If so, which side? And then talk about it. The examiner's going to include it. Functional impairment. Is there any additional functional impairment? Get issues with walking, sitting, standing for extended periods of time. And then any additional remarks. These remarks, they may include things, they may not. Oftentimes, if there's a new diagnosis which was new or different from the diagnosis in which service connection was granted, they may show a progression statement here saying, hey, this new diagnosis is a correction of the previous service connected condition, and they will specify here. To make this a valid exam, they do have to sign it, they do have to print their name, put in their MPI number, and all the other information here regarding their medical background. If not, then any of these boxes are missing, then this form is not valid. Okay, she made it this far. You're going to be glad that she did. Let's talk about pain now. When looking at that DBQ, you may have noticed that if talked about pain, hey, is there painful in the motion? Is there pain in the extension and the flexion? Where is the pain? Okay. Now, 38 CFR 4.59 talks about painful motion. Talks about granting a 10% evaluation for painful motion. One thing, if you did not know it, pain, regardless of where it's at. So, if you file a claim for, hey, I have increased pain, pain has gone up. So on a scale of 1 to 10, if you're living at a 9 on the regular basis, regardless of whether you're living at a 9 out of 10 or a 2 out of 10, it still only yields a 10% evaluation under the VA rating schedule, okay? Not great, but keep in mind that the way the VA looks at it is painful motion is 10%. Anything above that has to do with range of motion of your knee, flexion, extension, and other additional things, be it instability or those tears of the ligaments which are incomplete or which are, have been repaired, failed repaired. That's where the greater evaluations come from. Wrapping it up here with additional rating considerations and conclusions. Okay. As I've shown, pain, while important, doesn't matter if it's at a 9 out of 10 or a 2 out of 10. Pain's only 10%. After that, it all comes down to range of motion. Okay. Now, as I'd mentioned earlier, be honest, be upfront, be truthful about all the symptoms that you're experiencing. And if there's a limited range of motion, be it deflection or extension, then please indicate that to the examiner. Explain that to the examiner. Talk to the examiner about it. Have that information accurately notated on your DBQ. If you feel like the examiner did not do so, then submit. If you have private treatment records, have those submitted, which show an impaired range of motion of your right knee or left knee or whatever joint you're applying for. Okay? The VA rater, when considering the evidence, has to consider all evidence in the file. They have to consider all the evidence that's in your service treatment records, the evidence that's in the DBQ, and the evidence that's in your private treatment records that are in the file. They have to consider it all and then synthesize that information down to what they feel is the best or the most consistent range of motion or the most consistent symptoms as a whole. Okay. Now, that's tough. right? How can a VA rater look at what's in your service treatment records, what's in your private treatment records, what's in, your exam and your DBQ, and then determine what's what? Well, they're trained to do so, and the more information that you can provide, evidence-wise, the likelihood of getting an increased evaluation goes up. So, now that you know that, you know what to do. Don't embellish things. Be honest. Be upfront. Talk about all the symptoms you have. Anyways, we're going to wrap it up there. Please like, subscribe, leave a comment about what you thought or what you would like us to address in the future. I'm Mr. X, and we'll see you next time.